Dr. Millens told me that you start 2 minutes before so that the program can start at sharp 9:30. So that's why I'm starting a minute or 2 minutes before. And now I'll hand over again to our discipline master, Dr. Milan, to take over the charge. And it's a good, Mother, it's very good that everybody feels that we are totally a disciplined soldiers. So, Milind, the platform is yours.
Hi, good morning, everybody. Dignitaries, respected seniors and colleagues. So, welcome to day 2 of this AOC 2024 Top 10 Advances meeting. And we had a good time yesterday. We covered quite an array of topics in cardiology. And again, today we have a similar variety of topics. And to begin, there have been so many advances in terms of therapeutics over the last 2 or 3 years. In particular, some anti-obesity medications, a lot of cancer medications and their toxicity, and Vericiguat and things like that. So we have the first session on therapeutics, and I invite the chairpersons, Dr. Kane sir and Dr. Dargat sir, to please ascend the dais and take over proceedings. Thank you. Just one request again, we are going to be a little sticklers for time, so everybody is requested to please adhere to their time limits, both for the talks and the discussion. Thank you.
Good morning, everybody. Welcome to all of you. I think first topic is Dr. Kane is taking his varicocele, the new molecule for the heart failure. I think over to you, Kane sir.
Good morning everybody. It's always a pleasure to be a part of AOC Symposium. I want to thank Dr. Pelajani, Dr. Satyavan Sharma, Dr. Gupta, and Dr. Milind, our young star, for organizing such a beautiful meeting. And I hope today's also will be a great day for everybody to listen and discuss some of the issues we are facing in our practice today. So my topic is targeting worsening heart failure with Vericiguat. Basically, where do we use this new drug? So that's the whole question. How do I go down? Okay. At the outset, I just want to go through, because heart failure, we all know that despite so many advances over a period of nearly 30-40 years, we are still faced with very high mortality, very high morbidity, and very high costs to the exchequer, to the family, to the society. So roughly going into some of the advances, we can make out that from 1980, we used to use only digitalis and diuretics. There was nothing else. Then came beta blockers. We realized AC inhibitors, aldosterone, isosorbide, hydralazine, especially in blacks. And then there was a interventional treatment like ICD, LVAD, CRT, and of course, transplant. For nearly 14-15 years, we hardly had any new advance in that, and from 2016, this ARNI came into existence, and subsequently we also have this gliflozins which have come, and now today is the Vericiguat, and there are still more drugs coming up. So last 5 to 6 years, we have seen some real advance, and in our practice, we have realized that these drugs are really important. They do benefit a lot of patients who were not benefited by the earlier drugs, and you can prolong their life, or you can decrease their hospitalization and improve their lifestyle and day-to-day activities. So these are some of the good things that are happening. So what are our aims? When we treat heart failure, we all know that despite all advances, everything available, even transplant, we cannot treat everybody, and even if you treat everybody, the mortality has gone down a little, but still it is quite high. So we need still more advances to somehow treat these patients. So obviously any treatment that you do, the main aim is to decrease the mortality. We don't want the person to die. However, we know that it is not always possible, and the next aim in a heart failure would be to decrease hospitalizations, improve the quality of life, increase the functional class of the patient, decrease the healthcare, and all these, mortality is one part of it. All the other things are equally important. As and when anybody wants to live, he wants to be independent, he wants to be free of admissions to the hospital, And the healthcare cost, if somebody gets admitted, it is not only the patient who is admitted, if the whole family almost gets admitted. So they run around him, the cost and then the mental agony of the whole family. So it's a big problem. So what we have realized that if we cannot reduce mortality, we should be at least making them symptom free, improve their functional class, and improve their quality of life, and decrease the number of hospitalizations. Because as I'll show you later, every time a heart failure person gets admitted, the mortality goes up. And I have a nice slide to show you that. So we have now realized in the 2021-22 that we have these 4 pillars of heart failure: ARNI, beta blockers, MRA, and SGLT2I inhibitors. So these have become our standard of care now. Now, this being the standard of care, are we happy? Is it the end of the story? Unfortunately not, because despite all this being used in the right doses, still we have a higher mortality, still the patients get admitted, and that is the aim of my talk today, because you do have patients with worsening heart failure. So despite taking all these drugs, there are patients who develop worsening of their heart failure and they have to get admitted, or they have to come to the emergency department with the breathlessness, with edema. So these things do happen. So worsening heart failure is the next step in our treatment armamentarium, because all these previous 4 drugs were tried and established in chronic heart failure. They were not tried in acute heart failure or worsening heart failure. Most of those drugs, and then we have extrapolated them and we use it everywhere, and we know that they help. So when a person worsens on this treatment, that's called worsening heart failure. So it has a classic definition. It has to have a deterioration of heart failure signs and symptoms in a patient with established chronic heart failure despite stable background therapy with the 4 pillars of this. And this requires urgent escalation of therapy, including hospitalization, emergency department visits, outpatients IV diuretic therapy, or outpatient escalation of oral diuretics. Now this outpatient IV diuretics and oral escalation is a Western concept. In our case, whenever a patient comes in the emergency department and he requires IV diuretics, obviously he gets admitted. You don't send him home. I have never sent anybody by giving IV diuretic and then go home. So at least 24, 48 hours he'll be kept to sort of stabilize him. You have to go through all his drugs and see what you can increase, what you can do. So that is what is the most important topic for today. And why this is important is because worsening heart failure is associated with a 4-fold increase in 1-year mortality, as you can see from this graph. Next, each hospital admission, the survival decreases. This has been elegantly shown in number of registries and number of trials. So every time a patient gets admitted and worsens, there is some reason why he does that, and then subsequently his mortality goes up. So guidelines now recommend optimizing therapy in hospital or scheduling an early follow-up. So we now have a rapid escalation of all the 4 drugs within 4 weeks, because the previous regimen used to take several months to go to the proper dosages. Now we do it more rapidly. So initiate multiple therapies early is the concept, but there are lots of ifs and buts into that. You have to look at blood pressure, you have to look at electrolytes, you have to look at what happens to creatinine. So all these things are there. Even patients receiving quadruple therapy remain at risk of worsening heart failure and death. That's what I said before also. So 1 in 7 patients experience a primary outcome event despite confirmed use of quadruple therapy. So we do need more. We need something more. So this is a novel drug, Vericiguat. So far we were playing on neurohumoral modulation with sympathetic nervous system, RAS system, and then cardiometabolic and cardiorenal modulation with SGLT2. Now people realize that you can use one more pathway, which is the nitric oxide cyclic GMP signaling pathway, because whenever you have heart failure, there is always a local oxidative stress at the myocardial level, and that produces deficiency of nitric oxide, and because of that this soluble guanate cyclase is not getting activated, and you have fall in cyclic GMP level, which causes aggravation of this endothelial vascular dysfunction, myocardial dysfunction. So this pathway was so far unexplored, but now this is the pathway which Vericiguat has exploited and has shown that it is very beneficial. So we'll see what is the benefit. So how does this Vericiguat drug? It is a direct stimulator of soluble guanate cyclate, which increases the cyclic GMP, and you can see the benefits of cyclic GMP escalation, that you can do so many things with it. There are multiple benefits. Okay. Now what they found was in this Victoria trial, which established the role of Vericiguat, most of these patients were on all these drugs and still the drugs showed benefit. So that's the advantage of it. So symptomatic chronic heart failure after a worsening event, they were divided into two groups, a placebo and gradual increase in Vericiguat from 2.5, 5 and 10 milligram. Around 5,000 patients were randomized in that. And only thing was that they should be off diuretics, IV diuretics, and the blood pressure should be at least 100 millimeters systolic. And they found was, what was the primary endpoint? We have this something called as primary endpoint, which confuses everybody. It is a combination here of heart failure, hospitalization or cardiovascular death. Now this was reduced. If you really see, there was no change in the death, as I will show further. The main reduction in heart failure hospitalization. And that is one of the reasons FDA has not put this drug as class 1 indication, because FDA requires mortality benefit to make it class 1. So that's a discrepancy. Europeans and Americans don't agree on this, because there's so much of benefit. We have to give importance in heart failure to even hospitalization, symptom relief, all those things are also equally important. So the primary composite endpoint of all-cause mortality and heart failure was significantly reduced with Vericiguat. And also, this was also manifested by fall in pro-BNP levels. So that means the primary effect of it was on the heart and not anywhere else. That's what is probably derived from this, that it reduced pro-BNP. There was no much difference in the systolic blood pressure, so this is a good thing. There was no much difference in electrolytes, this is another good thing. And that is why Vericiguat is consistently recommended for patients with HFrEF following a worsening heart failure event, and it has been classified as 2B in most of the trials. So you can see Vericiguat may be considered in patients from class 2 to 4 who have worsening heart failure despite treatment with all the 4 pillars of our medicine. So this becomes a quantuplet, I think it is called, because 4 drugs and you have to be always having Vericiguat with you, because these patients are bound to worsen. There are also issues with it, I'll show you later. So initial therapy, first decompensation, you should see that you definitely aggravate the therapy, add Vericiguat to the existing drugs, and this is the way we have to go, 2.5 to 5, 10. This is just an example, I don't think that's important. Now this is the most important slide. Which are the patients now you can give Vericiguat? So the first thing is, if you have a patient who experiences a decompensation under optimal background therapy, this is what the trial tried. Second is, if you have a patient who experienced decompensation event after suboptimal background therapy for whatever reason, patient could not tolerate the 4 drugs properly, there was some side effect of those drugs. So all those things are contraindications. Vericiguat should be started on whatever the 4 drugs which are tolerated in whatever dose they were tolerated. That is the second indication. And the third indication is a patient has experienced a decompensation event under suboptimal background therapy, but complaints of background therapy is, so the true background therapy is possible. So you have to put all the drugs, you aggravate the background therapy also, you also add, because you may not have the time to add this drug if you wait for a longer time. So Vericiguat is very important, ladies and gentlemen. We have to find the right patient. It's not the first line therapy, but if the first line therapy is not possible for whatever reason, or the first line therapy is suboptimal, blood patient is suffering, and definitely patients who are on 4 drugs and it fails to give enough relief, Vericiguat is the treatment of choice. Thank you very much for your attention.
Thank you, Dr. Kanesh.